Today's lecture is on uterine artery embolization, and this is another very upcoming part of intervention radiology. We have taken a lot of classes till now, which have been more for the purpose of the exams. This is one topic which is actually very practically relevant for people who are planning to do intervention radiology as a specialty per se, because this is an OPD procedure or a daycare kind of procedure, small procedure that you can kind of manage the entire thing yourself again. Of course, you will need patients who will be referred to you. But if you can just read up a little more, get some experience in hand, this is a all in all separate topic where you can get a lot of patients with, especially for fibroids and adenomyosis. Of course, for PPH also we will be discussing today. That is an emergency situation where anyways you are going to get referrals, because at that time, gynecologists really need help. You want to prevent maternal mortality. You really don't need to, go out there and look for these. They will come to you. But the part where, somebody has to put an effort is to get patients for fibroid embolization or adenomyosis, and that comes by people coming to know about this procedure. So there's a lot of effort that is going on in actually letting people know that this procedure exists. And I think from this class today, I do feel a lot of the students themselves in conceptual radiology should be able to understand what is happening and be able to tell it to their friends, to their relatives, and try to, we as a community have to tell people that this is a very good non-invasive kind of option that is available, and there's no point of suffering if you don't want surgery. Sometimes people take medical management, don't get the results, but they don't want myomectomy, or they don't want hysterectomy, or there are side effects associated with those surgeries which you are worried about. Is something where suddenly this option itself doesn't present to those people, and it is important for us not just to perform this procedure but to be able to inform people about the same. We'll start the fact that there is a lot of things where we have started taking the role in women health per se. Today we'll only be talking about uterine artery embolization, but even there's ovarian vein embolization, like varicocele embolization for pelvic congestion syndrome. Then DVT and varicose vein is quite important with a lot of females suffering post pregnancy. There's deep vein thrombosis. Varicose vein is very common. So this are all spectrum of women's health, but we'll be focusing on uterine embolization. First, we'll be dealing with the fibroid and adenomyosis part, and then I'll be talking something about the PPH as well. So fibroids, the first idea is these are primarily benign tumors. We all know that, and they are estrogen dependent. So we know these will peak during the years of menses, and pre and post menopausal, these will anyways go away. Traditional treatments, a lot of people are undergoing hysterectomy left and right if their families compete, or push towards myomectomy, say, because their third option is not being shared. The problem with hysterectomy is that there is perioperative complication risk, and there is a premature menopause which people are not told about. Women are just happy that the symptoms of fibroids are gone. They don't realize that they will have perimenopausal kind of symptoms. They will have bone weakening, weight gain. So there's so many things which come from premature menopause. Myomectomy again is an invasive procedure. Of course, if somebody is looking for fertility, we still don't have enough data to say embolization versus myomectomy. So we end up, letting people go for myomectomy in those cases. But once the family is complete, again, there's really no major reason why somebody who is a candidate for uterine fibroid embolization is not offered the same. Of course, there are certain areas where the treatment is difficult, sizes are such, or the location is such which is not favorable for fibroid embolization. But otherwise, the results are extremely good. So what happens in uterine fibroid embolization? We'll be talking about that. The first time this was brought up was as a pre-op embolization kind of technique, where somebody said that, of course, I'm treating this large fibroid. Can you just reduce the vascularity? So they did that. It's not like India, private hospitals where people will get one procedure and the next day they have the date for the next procedure. So somebody got this embolization done. They got a surgical date 2 to 3 months later, and by the time they came for their surgery date and some scan was done, it showed that in any ways the symptoms are gone, the size has reduced. So they didn't go ahead with the surgery. This is where, we started developing this technique. We realized that, what was started as something as a preoperative embolization itself can end up being curative for the patient. So ideal fibroids which can be treated by this include intramural fibroids. So normally by the FIGO classification, we take like something like 2 to 5 as the ideal candidates. But the second part is the size. So less than 10 centimeters, a good size. More than 10 centimeters, you start having ectopic supplies, and the chances that the pressure symptoms might persist for a slightly longer period of time. The expertise involved becomes more, you need a more expert operator to deal with these kind of tumors. The post-embolization syndrome or the pain, ischemia related pain that happens increases when you have larger sizes. So that is where, we start thinking about giving other options or surgical options to the patient. Good vascularity, of course, if the vascularity is good, then only removing the vascularity will be useful for the patient. And we rule out other causes. So if there's any infection, there's anything else, hemorrhagic cyst, endometriosis, everything has to be seen so that you don't end up doing a treatment and the patient continues to have the problems that they were facing anyways. Patient who is ideal, again, I said either premenopausal, of course, we know postmenopausal fibroids will just reduce in size. There's no point of going in and doing anything. Menstrual issues is a better patient. So who's having bleeding will have a much higher rate of success than bulk system symptoms or non-specific pain kind of symptoms. They will take time and end up sometimes continue to have the problem, and they'll say that maybe it's because of the fibroid embolization. But there are people who get hysterectomy done and still don't get relief. That is because the symptoms were more of non-specific pain kind of symptoms. Again, as I said, we look for completed family because we still don't have enough data to say that myomectomy and fibroid embolization have similar fertility rates. Though, as I said, fertility has been documented after UFE. It's not like UFE will lead to infertility. So that is a misconception. If at any point of time, because when you're doing it for PPH also, we are doing it. So it's for primies a lot of the time. We don't want to take the patient for hysterectomy straight away because patient has not had a baby. So they still have fertility after the PPH case. So why not after this? And there are documented uh, pregnancies after UFE. But again, the rate, the possible complications, we don't have enough data. So we try to take up patients who have completed their family. They want their uterus preserved, or they are, of course, unfit for surgery and not desiring any kind of surgery, afraid of complications of an operative procedure. So that's an ideal patient for us. Clinical and imaging selection has to be good. We have to match the patient's criteria. As I said, if he is facing having hemorrhage, of course, we can give them a higher confidence and set their expectations accordingly. That definitely you will get a good result. But if they are non-specific pain or very large pressure symptoms, you just have to tell them it will take some time so that you don't come out feeling that the procedure did not work for them. We get an MR after the ultrasound. For ultrasound is where we usually diagnose this. And from there, we do an MRI protocol. We do three-plane T2, a T1 non-fat SAT, T1 fat SAT, and a post-contrast SAG. So on the basis of these, we figure out the size of the uterus, the number of fibroids, the size of the fibroids, the location, whether they are pedunculated, whether they're vascular, do they have already degenerated? Because sometimes fibroids with pain and degeneration will not perhaps give that kind of result because the area is already degenerated. The vascularity has nothing to do with it. And adenomyosis is actually good, if there is adenomyosis, but we need to change the technique a little because myomectomy alone may not give you relief, but UFE can give you relief from both fibroids and adenomyosis. Only we need to take smaller particles for embolization. Of course, pelvic vasculature you can study in the post-contrast images. You can take the angiographic phase, ask them to take an early angio phase also before you take the post-contrast images. And that will help you plan your procedure, the angles in which you will be able to see the uterine artery well. Preparation would include, removal of